Bueno, ahora el doctor Dajilla, sorry, nos atacan. El doctor Dajilla va a hacer una clase sobre la patología que probablemente origine mayor cantidad de órdenes de examen de ecografía Doppler, que es la trombosis venosa profunda de extremidades inferiores. Así que en términos de prevalencia, probablemente esta sea la clase de mayor prevalencia, por lo menos en la realidad asistencial de nuestro país. Después de eso, la doctora Paulinelli nos va a hablar de insuficiencia venosa de extremidades inferiores, donde ella probablemente sea la persona más destacada para hacer ese examen en el país y la que ha publicado los papers respectivos y todo. Y después de eso vamos a tener el receso de almuerzo. ¿De acuerdo? Así que dejo con usted nuevamente al doctor Dajilla.
Thank you. Okay, I think a little break. We go from arteries to the veins. One talk on DVT and then the other talk on insufficiency. So the biggest problem with DVT is that it is fairly common, and almost 1 million people will have a PE or DVT. So we end up having too many exams, a lot of them negative, but then some of them critically positive. So it's important to pick it up. And especially I think with all the long distance traveling, the number of DVTs by people who recently traveled has gone up. Now, the American College of Radiology has a appropriateness criteria on the suspected lower limb DVTs, and at the top is ultrasound extremity, and all the other investigations can be used, but the front line in the ER and in radiology is always the DVT exam with the Doppler. More importantly, that this test is over the period of since 1993, if you see, the test has had a positive predictive value of almost 94% and is very highly sensitive and specific. So it's a good exam to do. Now, a couple of things I wanted to talk about anatomy because of terminology. And some of this you might know, some you don't know. The terms for the superficial veins are the great saphenous vein and the small saphenous vein. We used to call this one as a short saphenous vein, and the great saphenous vein used to be called as a greater saphenous vein, but generally now this is the two terms. The other critical difference from arteries is that the superficial femoral artery is called the femoral vein and not called the superficial femoral vein. The reason being that many internal medicine folks may not be fully aware, and sometimes just the word superficial may make them think that it is a thrombophlebitis or a superficial vein, and they may not start appropriate treatment. So by convention, femoral vein must be labeled only as a femoral vein. The other interesting concept is that all the intramuscular veins in the calf, even if they are not the named posterior tibial or anterior tibial, the soleus vein, the gastrocnemius vein, or any intramuscular vein is always a deep vein. It's interesting how complicated this becomes, because I get phone calls many times when I say intramuscular vein thrombosis from physicians who think that maybe these patients do not have a DVT. But anything below the deep fascia is a deep vein, and it is a DVT which needs to be treated if indicated. We use high-frequency transducers. The pelvic veins, you might have to use a curved transducer. Make sure there are slow flow settings. You don't have to worry about angle because we are not measuring any peak systolic velocity. And the Doppler sample volume can be large, like in this example. The Doppler sample volume is opened all the way from wall to wall so that you can look for flow even in the periphery of the vessel in case there is thrombus. It's not super critical, but it's a good sort of habit to have. Multiple positions for DVT exams, mostly supine or reverse Trendelenburg position with the lower limb abducted, slightly externally rotated. Sometimes you can perform it in sitting position with the legs hanging, and then make sure the transducer pressure is appropriately put, especially when you're doing compression maneuvers and Valsalva and distal augmentation, because sometimes you can knock out flow by increased transducer pressure. The examination protocol is from the inguinal ligament to the tibioperoneal trunk. This is a minimum. The origin of the profundus femoris vein must be shown. So if you have to take some transverse images in the proximal part, I recommend taking one image of the common femoral vein before the saphenofemoral junction, second image with and without compression of the femoral vein with the great saphenous vein origin, and a third image of the profundus femoris origin before you start taking proximal, mid and distal images of the femoral vein. Also examine duplicated veins. Almost 25% of the time the femoral vein or the popliteal vein may be duplicated. One may be thrombosed, one may be open, so important to pick that up. The superficial venous system is examined in the proximal portion. There is new data that says that if there is a thrombus in the great saphenous vein or the small saphenous vein within 5 centimeters of their junction with the deep vein, then it should be treated like a DVT. Not everybody subscribes to it, but the ER physicians would like to know, if you say there is a great saphenous vein, how far away from the great saphenous vein junction it is. So we usually put it in our report. Transverse plane images with and without compression, color Doppler to document the absence of flow, augmentation maneuvers in which you press the distal part of the limb to see if there is a response. Always look for Doppler waveforms from both the common femoral veins and assess for respiratory physicity. Loss of respiratory physicity is an important sign because that means something is wrong with the pelvic vein. Unilateral exams are acceptable, but even if you do a unilateral, you need to show spectral waveforms from both common femoral veins. This is critical because many times you will diagnose indirectly what is the upper extent of the thrombus. For example, if you have a thrombus in the right common femoral vein and the left common femoral vein has normal phasic flow, one thing is sure, that the thrombus has not extended to the IVC because the other one is showing flow. So that sort of helps in knowing what level it is. As clinically we have known over the years, the combination of a endothelial damage with stasis and hypercoagulable state, which may be because of disease, underlying disease, these are responsible for the DVT. It could originate in calf veins and then extend proximally. Therefore, calf vein DVT is also important to inform. Clinical presentations, I won't go in detail. You are pretty aware about these. How does the normal vein appear on ultrasound? So it has imperceptible wall, which means we hardly try to see where the wall is. It's hard to make out. It's very imperceptible. They are completely compressible. This is very important to demonstrate because in this case, they always call this the Mickey Mouse sign. You have the femoral vein and the saphenous vein and the femoral artery. And when you compress, you can see that the vein and the saphenous vein both disappeared and the femoral artery is still patent. This compression is important because sometimes acute thrombus can be very dark. You may think that the lumen is open, but when you press, it does not compress. So compression is actually the cardinal feature for testing for DVT. Spontaneous flow is important with respiratory phasicity. So if you are looking at this image, the Doppler sample volume is in the vein, and this is normal phasic variation as you expect with respiration in any vein. So it is sustaining itself. Temporary cessation with Valsalva and increased flow with augmentation. Two opposite things that we do with the veins. So here the patient has done a Valsalva. The moment the patient did the Valsalva, the flow stopped or even reversed for a little bit. And then when the patient started breathing again, you can see that there is a nice flow, antegrade. Distal augmentation is done by the operator. So you have your Doppler sample volume in the vein, in this popliteal vein, and you press the cuff. And the moment you press the cuff, you can see a huge flow of blood. This is augmentation. and very useful to say that between this spot and where you compressed, there is no obstruction. Both these are very useful. By Valsalva, what are you showing? You are showing that because you are able to show Valsalva in the segment, between this spot and the heart, there is no venous thrombus, at least no occlusive thrombus. So these are really important to show in all the cases. Another example of that compression, another view of the femoral vein, and sometimes the patients have a lot of edema and you can't clearly see what is happening, but especially if a sonographer is doing these images for you, it is important because real-time evaluation, they can either send you a video clip which confirms the compression, or they can label it so that you know which one was the vein which disappeared. Normal respiratory phasicity, another example, and another example of the distal augmentation. Here's again Valsalva. You can see we are putting this in the femoral vein. There is a cessation of flow, and then again the flow starts. What do you see in the acute DVT? One, the vein is dilated. It's nearly double or more the size of the adjacent artery, obviously non-compressible. The thrombus is hypoechoic or lightly echogenic, appears spongy, and the borders are very smooth. You could be dealing with a poorly attached or a floating or a mobile thrombus. Why is this important to know? Because when you see this sort of a thrombus, you do not want to compress too much. You don't want to dislodge that thrombus and make it an embolus. So normally, you look at an artery, you look at a vein, and the vein is 2 or 3 times the size of the artery. It's pretty obvious that you're dealing with acute DVT. Here is a DVT, which is again acute, but you can see the head of the thrombus. This is the saphenofemoral junction, the proximal saphenofemoral junction. We know it is extending to the junction, but it has not yet involved the saphenous vein. You will see later on in the images that it is critical to comment on presence or absence of a thrombus that coexists in a saphenous vein. Because imagine what happens if the venous flow is obstructed in the deep veins and the superficial veins. That is really bad for the patient because he's going to go into venous gangrene pretty quickly. Here's another example of again a head of the thrombus, and it's like a cobra head there moving. This is the one you don't want to do too much compression and try and prove anything. It's pretty obvious this is acute DVT. So in the what happens in the spectral Doppler or color Doppler? Obviously there is absence of flow, but in the segment proximal to the thrombosis, there is diminished flow or absent augmentation, and in the segment distal to the thrombus, there is loss of phasicity or Valsalva response. And these become really critical when you have somebody else doing the exam. If you're doing the exam yourself, you may not have to do all this testing. So if this is a blood vessel, and this is the caudal part, and this is a cephalic part, and this is a large thrombus in the middle, so that thrombus portion obviously will not show any flow on spectral Doppler or on color Doppler. But there will be diminished flow or absent augmentation proximal to it. So you can imagine that the sonographer or you press here and you're sampling here. This is going to obstruct the augmentation, so you will see no change. So indirect evidence that there is a thrombus. And if you sample in this portion, this is not allowing the heart and the respiratory movements to communicate with the lumen. So you have loss of phasicity or monophasic flow. Sometimes the monophasic flow is the only sign in picking up a iliac vein thrombus. So it's important to look at that phasicity when you make the call. So here we have an example again of the femoral vein, and this is the deep femoral vein. The femoral vein here is completely thrombosed. It's very obvious on the exam. Now in the segment distal to the thrombus, if you notice, there is loss of phasicity and Valsalva response. The waveform is very monophasic, and if the patient does a Valsalva, it doesn't change. So this is indirect evidence that there has to be a thrombus which is proximal to this area, because there's no communication between the diaphragm movements or anything happening in the IVC down to this vein. So once you see that, you know there's something wrong which is more proximal to it. And in this case, the left common iliac vein distally was thrombosed. So you notice what we did here. You have to change to the curved transducer, find the iliac artery, and right next to that you find the iliac vein. So whenever you find a thrombus, if you have not told what is the level, then you have to change the exam and go higher. And if you look at the other side and that side also looks thrombosed, then you go even higher. And I tell my sonographers to at least start with the retrohepatic IVC, make sure that is open, and then go further down to try and find where the level is. That helps the IR team to understand if they have to put a filter in the IVC or not. Now this is an interesting case. We are seeing the great saphenous vein does not have any phasicity. It's very monophasic. And obviously you can see that the femoral vein has a large thrombus here. So this is finding some collateral circulation to bypass the thrombus. But indirect evidence is clear that something is wrong with the femoral vein. Otherwise, why will this vein look so monophasic? Here's another example, the femoral vein proximally, again monophasic. There is absolutely no phasicity. You know something is wrong more proximally, and you went proximally. This is the left external iliac vein, completely thrombosed. So like that, sometimes doing a little waveforms helps you to know where to focus and find the thrombus. Now the big question is, are the superficial veins also thrombosed? In this example, the femoral vein is thrombosed, common femoral vein is open, and the great saphenous vein is also open, which is fairly good for the patient because there is some mechanism for the blood to escape and go up. But in this case, the patient is not that lucky because now you have the femoral vein thrombosed, you have the great saphenous vein thrombosed, and the common femoral vein thrombosed. So now imagine that this limb does not have any mechanism to send the flow up, at least in the acute process. In the chronic process, some small collaterals will open up. And this becomes a kind of a dangerous question. Not only that, in this patient, the collaterals and the perforators are also thrombosed. These are all communication channels between the superficial venous system and the deep venous system. So this is a severe form of DVT, and it is called phlegmasia ceruleus dolens, basically extensive thrombotic occlusion of the major vessel and the collateral veins. And the patients can present to ER with severe pain, cyanosis, and edema. It's almost an emergency. They have huge risk of pulmonary embolism, even if these patients are under anticoagulation, and kind of precursor for frank venous gangrene. Many of these patients you find underlying malignancies, so they are tested with staging CT on them. And here's an image from our vascular surgeon she gave, and you can see how big and red and angry this leg looks compared to the other one. This is acute emergency, superficial venous drainage blocked, deep venous drainage blocked. Both sides are not going up. Interestingly, there's another condition called phlegmasia alba dolens, basically a white leg or a milk leg. And this is a little bit opposite of what we just discussed. And what happens here is once the extensive DVT happens, there is so much edema that there is early compromise of the arterial inflow. So it's like a compartment syndrome where the artery itself is now finding it difficult to send the blood in because the superficial system is not adequate to handle a large volume of blood which is coming down. And these patients basically have arterial ischemia, they look white, and it can be missed when you initially look at these patients. I also want to spend a little bit time about calf vein thrombosis. Most protocols quickly do a DVT and stop at the popliteal vein. But we encourage that everybody should look at the calf veins, at least the posterior tibial veins, the anterior tibial veins, and even the calf itself. If you find a calf vein thrombus, then the question is, what should you do about it? So I talked to our vascular group about it, and the way they do it is basically depends upon patient's morbidity or other coexisting conditions. Sometimes patients who have had recent hospital stay, post-arthroplasties, or known cancers, these patients are put on treatment right away because the risk of having a thrombus that creeps into the popliteal vein is very high. If there is no other comorbidity, then the calf vein becomes a little bit more tricky to manage. In some instances, they will ask for a repeat scan in 1 week. If there is no extension of the calf vein thrombus into the popliteal vein, they will ask a second scan at 2 weeks. And if there is no progression of the clot, then there is no further imaging, or the DVT itself resolves. Either way, these are patients who do not have existing comorbidities. So whether the patient is symptomatic or non-symptomatic becomes very important in treating isolated calf vein thrombus. Generally, once you come from the lateral side, you can show the posterior tibial artery and veins together. The artery runs in the middle. Most of the time, the posterior tibial veins and the peroneal veins are duplicated. Important to show that both are patent because one could be thrombosed. Here's a case in which the artery is patent and the posterior tibial vein, the paired posterior tibial vein like a sandwich on both sides is thrombosed, and the paired peroneal veins on both sides are also thrombosed. So definitely a calf vein thrombus involving both veins. Here's a transverse view going up and showing you how the paired veins are seen, and you can see a big thrombus in one vein. And this also demonstrates the sort of technique with which our sonographers follow these veins. Invariably, these sort of videos are taken all the way from the common femoral vein all the way to the calf vein. And when you focus in that manner, it is very less likely that you are going to miss anything. Always in the calf, always look for the symmetry. You can see here the artery is in the middle. This is a very dilated channel, one of them, and the second channel is a little less dilated. But there does appear to be thrombus on both sides. So again, this is an important mechanism to look for the calf vein thrombus. What happens to the thrombus with time? Most of the residual thrombus with time will become a fibrous tissue. Collateralization starts taking place pretty quickly, and collateral veins may not be visible on ultrasound. So the fact you don't see it doesn't mean that they don't exist. About 2 weeks after an acute DVT episode is the subacute DVT phase. It's more likely, I only call it if I have a previous ultrasound exam. If I do not have a previous ultrasound exam, I don't know the timeline. It becomes very difficult sometimes to tell the clinician whether to start treatment or not start treatment. Some patients are very tricky. They have high risk for intracranial bleed if they start oral anticoagulants. So the clinicians will talk to you and say, can you age this? And we're like, if you don't have a previous exam, it's difficult to age a thrombus. And I will dictate it as a indeterminate age thrombus when I don't know what's happening. Is it subacute? Is it acute? It's a little difficult. How will you know that something is subacute? There might be slight increased echogenicity of thrombus. There is reduction in venous distension. It is a little bit more compressible, and the thrombus sort of starts gravitating towards the wall. On Doppler, you might see some foci of color coming back because of recanalization, and then you will start seeing spectral flow. But remember, these vein walls are damaged. Because these walls are damaged, you will see loss of phasicity in a lot of these veins. You might see sluggish distal augmentation, and because the valves are damaged, you also might see incompetence, and I think we'll hear more in the next lecture. So here's a DVT. This was the thrombus, and this is the artery. We press. There is still some compressibility, but not as bad as completely acute thrombus, which does not compress. So you start thinking that this may be becoming more spongy. That's why it is a little bit more compressible. And sometimes I'll just measure it to show the residents what is happening after the compression. In this case, the popliteal vein, you can see a little bit echogenicity increase, some recanalization in the middle. So this echogenicity is not as hypoechoic as you would expect in acute DVT. So maybe it is subacute. It has also started reaching the same caliber as the popliteal artery. And in the long view, you can see there is some of the thrombus which is trying to open up some lumen on the side, and you can always sample that flow. So this is important, especially if you have a comparison to see that there is improvement taking place in the volume or the burden of the clot within the vessel. Now, what is chronic DVT? Historically, we use the word chronic many, many times, But I think recently the preferred term is chronic post-thrombotic change. And we've used this effectively because it helps you and makes you not commit to a fact that it is chronic indeed, because chronic post-thrombotic change is like an umbrella, and a lot of things can happen to the vein as it tries to heal itself. Our worry was that when we called chronic thrombus, the physicians might continue treating, thinking that it is some sort of a residual thrombus. So that is why the terminology changed. What happens in the chronic stage? The thrombus now is rigid. The vein may be contracted, may be equal to the artery. The walls may be very irregular, might see large collateral veins, obviously incompetence because of abnormal valves. And again, very similar to the subacute phase, some degree of flow might be seen in the vessel itself. So here's an example of a chronic post-thrombotic change. You can see there is chronic wall thickening both sides, but the lumen has nicely opened up. So this is post-thrombotic chronic change. Nice, decent flow within the lumen. In fact, even augmentation was demonstrated. Here's another one. You can see duplicated vein here. One got compressed, the other one is not fully compressed, but the caliber is similar to the artery or less than that nearby. It tells us that this is a chronic phase. Again here, not fully compressed, but very echogenic, so chronic phase. Here's another one in which you can see this fibrinous material, septae-like linear echogenicities within the lumen, but the flow is still there, monophasic, loss of phasicity. We expect that, but the caliber is less than the artery or equal. So this is a chronic phase, post-thrombotic chronic change. Another example of that little wall irregularity and loss of phasicity, post-thrombotic chronic change. So I really think that's the word you have to use more often. Now, sometimes the sonographer will come and tell you, oh, there is arterial flow in the vein. That can happen. It is not unexpected, especially in a chronic DVT. Because what happens is there is vascularization from the wall of the vessel itself, and these vessels can invade the thrombus. They sort of form these small AV fistulas within the vessel itself. You don't have to do anything about it, but it can look a little disconcerting because you can see arterial flow in the thrombus. So here's an example. One is an artery, atherosclerotic change, so a little bit narrow lumen. Other is the vein. And the vein is also showing sort of flow which looks as if it is in the artery. And when you sample it, you can see that little tarsus parvus type of flow. This is neovascularization secondary to the vasa vasorum from the wall itself. Nothing to be worried about. It is still in the category of post-thrombotic chronic change. You can definitely say arterialization of the chronic thrombus is noted, but there is no acute DVT, and that's the most important question to answer. Here's another example. You can see there is a chronic thrombus, some arterial flow inside, but otherwise it stays occluded. Multiple ways we can do this chronic post-thrombotic change with acute DVT, but I think basically you look for the fact that the vessels are patent again a little bit, irregular borders, and the vein will be contracted compared to the acute stage. There are many limitations and pitfalls in DVT. We all who do it will see that sometimes there are bandages, patients have a lot of edema, large body habituses, a lot of hardware, especially orthopedic hardware. The blood might be really slow because of a long hospital stay, and sometimes you can be fooled by that. The augmentation helps, dangling legs on the side of the bed helps, so all these areas can sometimes help. Plus there are other pitfalls, on a DVT exam which can look like a DVT. If you are quickly doing an exam, here's an example of a lymph node, a bad malignant lymph node in the groin, but with a lot of vascularity, not a DVT exam. This is lymphatic flow, so you can see lymphatic fluid within the space between the subacute fat and the deep muscle. So this looks like as if a superficial vein is thrombosed, but basically it is just the appearance of flow. And this is a superficial vein that is thrombosed, which can be misread as a DVT, but this is the deep fascia. So always look at where the fascia is in relation to the thrombosed vessel. So skin, subacute fat, and then the vessel, then the deep fascia, then the muscle. So this is a superficial vein, not a DVT exam. Duplicated veins can always hose you because one of them is thrombosed, the other one is open, the other one got compressed, this one did not get compressed. So it's important to keep in mind that these are all pitfalls. And then this rouleau formation, very slow blood flow. It looks like there is a big thrombus if you compress, completely compressed. So there is no thrombus in there. This was just very slow RBCs coalesced together and flowing very, very slowly. Hematoma in calf muscles, many times mistakenly called as DVT by even our sonographers. This is the gastrocnemius muscle. There's a hematoma inside tennis leg, usually at the myotendinous junction. And the artery is here. We called this as DVT, but later on we realized that the vein was here at the bottom. Patient had to be called back, scanned again, and the vein is going posterior to the hematoma. So again, a big pitfall in this situation. And then one of the last cases is this intravall hematoma. The cardiologist and I, we talked a lot about this because I called it a DVT, and he said there is no way this is a DVT because patient does not have any other symptoms, no swelling of leg, nothing, just pain. So investigated him again a little bit. Initially here, this is what convinced me it's DVT. I'm like, this is the artery, this is the vein which is not getting obstructed. But on the repeat scan, I realized what happened. The hematoma was in the wall of the vein. Okay, so there is a hematoma here, there's a hematoma here, but the lumen is open. The lumen is open. It's just the circumferential hematoma in the vein. So when I pressed, or when the sonographer pressed, the lumen was finished, and this whole thing looked like a DVT, but actually was an intravall hematoma. And obviously, the patient did not have to undergo anticoagulation on this. Last but not the least is fibrin sheaths. Many times they will have some fibrin sheath, especially related to some sort of dialysis or anything in the leg. So, or sometimes the cardiologist will leave it for some time. You will have some thrombuses come next to that sheath, and that's called a fibrin sheath, not a DVT, and should not be treated because that would qualify as an overtreatment. So in conclusion, DVT remains an excellent first-line investigation. As you saw, some diligent protocol and scanning technique is required, and anatomy knowledge is important to avoid pitfalls. Thank you very much.
Hola, muchas gracias por la invitación. Espero que después de una mañana ardua no se queden dormidos con esto. Es un tema que es bien bonito pero requiere como harta paciencia, así que paciencia les pido para la presentación. Los objetivos van a ser conocer la anatomía del sistema venoso, el superficial principalmente, aprender la fisiología normal y la fisiopatología, porque a través de eso podemos llegar a ver y a entender y hacer un examen adecuado y en cómo hacemos en la práctica el examen. La insuficiencia venosa es la incapacidad de que la sangre llegue hacia el corazón y todo lo que vemos ahí son síntomas, las varices, el edema, los cambios tróficos de la piel, todos son síntomas de una insuficiencia. Y esa es la que tenemos que rescatar y la que tenemos que detectar. Anatómicamente, bueno, esto es muy básico, que hay sistema venoso profundo por dentro de los músculos o de la fascia muscular, sistema superficial que está por fuera de la fascia muscular, un sistema comunicante que comunica los sistemas superficial o profundo, que es el morado, y el sistema perforante que comunica los dos, el sistema superficial con el profundo. El profundo ya el doctor habló muy bien, lo único que decir que es el encargado de llevar el flujo ascendente hacia el corazón. Y del sistema superficial nos vamos a tener un poco más porque hay dos tipos, uno que está por dentro de lo que se llama la fascia safena y que se llama el sistema interfacial, y el otro sistema es el epifacial que está por fuera. Los que son interfaciales son los safenos, safeno interno o mayor, safeno externo o menor, y que se caracteriza porque esta es la safena que veíamos, esta es la safena y esta es la fascia safena que va por fuera y forma una especie de ojo. Y así se ve en longitudinal. ¿Y por qué es importante? Porque esta es capaz de retener, de contener el vaso y que no se dilate en forma significativa. El otro sistema es el epifacial y es el que frecuentemente más vemos dilatado porque efectivamente no tiene esa contención y que nace o descarga en realidad hacia el sistema safeno. La safena mayor, un recuerdo anatómico rápido, está ubicado en el compartimento, especialmente visible en el muslo y en la pierna. A nivel de la rodilla y del tobillo a veces se pierde esa compartimentalización, pero es importante siempre reconocerla y sin mirar las otras venas que pueden estar al lado, mirarla entera para ver si está suficiente o no. Y así la vemos abajo en el tobillo, alrededor de la tibia, eso lo hemos visto en el paso. Esto es bien importante, la unión safeno-femoral, que está localizada entre la vena que llega, la safena que llega hacia la vena femoral común, donde está la válvula terminal, y la válvula preterminal. Esta válvula impide que el flujo de la femoral común se vaya hacia la safena, y la preterminal impide que el flujo que viene de las colaterales superficiales se vaya hacia la safena. Por lo tanto, esto es la unión safeno-femoral. Me contaba un colega cirujano vascular que para ellos es muy importante saber, cuando uno le hace los mapeos, la existencia de estas tributarias para el tratamiento. Entonces las tributarias podemos diferenciarlas en las que son hacia arriba, que son, esto es un esquema, un cadáver que está inyectado, no, perdón, esto es una tomografía computada, que son la epigástrica superficial, que es la que vemos habitualmente, la más común. Acá está llegando la safena, acá está la femoral común y aquí va llegando la epigástrica superficial. Tenemos la pudenda externa superficial que también va llegando ahí. Tenemos la circunfleja ilíaca superficial que llega por el otro lado, por fuera. Tenemos la safena accesoria anterior, que así se llama ahora, que es bien frecuente, que es muy importante reconocerla. La safena accesoria posterior y esto que lo constituye la red venosa ganglionar. En la ingle hay muchos ganglios, muchos grupos ganglionarios o de linfonodos. El más constante es aquel que está ubicado entre la safena mayor y la safena accesoria. Si ustedes van haciendo un barrido desde arriba hacia abajo, vamos a ver la safena mayor, la safena accesoria y este ganglio en medio. ¿Y por qué es importante? Porque este ganglio está comunicado o está con el sistema profundo a través de una perforante que va a la femoral común. Y además a través de él pasan venas que vienen de la safena interna y la safena accesoria. ¿Y por qué esto es importante? Porque esto es causa de recidiva. Acá vemos en una foto de un libro la perforante y uno puede encontrar esto, el ganglio con venas dilatadas que se producen por esta insuficiencia de la perforante, y cuando ha sido operado, por ejemplo, uno encuentra esto a nivel de la ingle y es secundario a eso. La accesoria anterior es esta que llega acá, que es la que vemos, es muy constante, y las accesorias posteriores que pueden nacer a nivel de la pierna, del muslo o a nivel de la pierna. Y las comunicantes son accesorias circunflejas que van entre los sistemas, como les explicaba, superficial o profundo, entre ellos, digamos. La safena, ¿cómo distinguimos la safena interna de una safena interfacial, de esta superficial, tributaria superficial? Si uno va, por ejemplo, que sea esta, uno va cortando, va hacia abajo, tenemos la safena interna, la safena mayor, y sale un vaso hacia afuera. Y ese vaso que sale habitualmente es de mayor calibre porque no tiene contención y lo podemos diferenciar. Ahora, para tener una idea cuáles son los patrones de la safena interna, como para saber qué es lo que nos podemos encontrar, es que tenemos un vaso que va desde abajo, desde la región medial del tobillo, perdón, hacia el callao. Podemos a veces en algunas partes estar duplicados, están en el mismo espacio. Acá ya tenemos una safena y safenas accesorias laterales, mediales, como son estas de acá, o arcos posteriores se llamaban antes. Podemos encontrar un arco posterior, pero en que se interrumpe la safena interna, que no se ve, y otras veces se interrumpe y luego se recanaliza. Todas estas son cosas que uno puede ir encontrando. La safena menor, llega hacia la región poplitea, también está ubicada en un espacio interfacial que es un poco distinto, un poco más pequeño. ¿Y cómo drenan al sistema profundo? Porque siempre tienen que ir drenando. Entonces, uno puede ser a través de la unión safeno-poplitea, a través de una unión safeno-muscular. A veces la safena externa o menor llega hasta acá, solamente uno no la ve allá. O puede drenar hacia el sistema, a través de la anastomotica magna, hacia el sistema safeno mayor, o a veces no haber uniones safenofemorales. No es infrecuente que uno se encuentre con esto. El sistema perforante, dijimos que es un sistema que comunica los dos sistemas superficial y profundo. Y importante es que los callados o las uniones safenopoplíteas, safenofemorales, son una especie de perforante, que llevan la sangre del superficial al profundo y las perforantes también, del superficial al profundo. Acá la vemos cómo va el flujo hacia profundo. ¿Cómo se estudia y no morir en el intento? Porque en realidad en los principios se agobia, hay muchas perforantes y obviamente uno no ve la mayoría de ellas. Entonces lo que tiene que hacer es buscar la fascia, y donde hay un espacio, un defecto en la fascia, ahí hay una perforante. Y hay por delante, por medial, por posterior, por lateral, ya en el paso les muestro más o menos dónde se ven las más frecuentes. Estas siempre busquen que son las paratibiales, las tibiales posteriores. Nombres propios ya no, por lo menos nosotros no usamos, porque no son confusos en realidad. Así, está bien. Ahora, fisiológicamente es importante entender que para que haya un flujo ascendente necesitamos un sistema venoso permeable, como decía el doctor, necesitamos un corazón que funcione bien, que tenga una buena función diastólica, y una bomba válvulo-muscular. ¿Qué es lo que es la bomba válvulo-muscular? Es esto, que está formado por músculo y por las válvulas. ¿Y por qué? ¿En qué sirven las válvulas? Si nosotros tenemos una columna líquida desde 1,60 m hasta abajo, la presión a nivel de tobillo es muy alta. Entonces las válvulas lo que hacen es ir descontinuando esa columna para que la presión que llega abajo al tobillo sea menor. Ojo que el 75% de la sangre está en el sistema venoso. Cuando este es el músculo, estas son las válvulas, este es una perforante, un callado. Entonces, tenemos en el sístole muscular, el músculo se engruesa y comprime los vasos. Al comprimirlo, el flujo se va hacia arriba, se puede producir un trasciente reflujo a través de una perforante que después se cierra. Y en el diástole se produce una distensión del músculo, un efecto como de esponja que atrae el flujo y ahí se prueba la válvula. Y en ese momento, al aumentar la presión acá, puede verse la insuficiencia ya sea de las válvulas, de la vena como de las perforantes. ¿Cómo estudiamos las válvulas? A través de forzarlas, pegarles para ver si se pueden dilatar. Entonces, ¿cómo lo hacemos? Uno, aumentando el flujo arriba, aumentando el flujo por sobre hacia el corazón, con lo cual vamos a tener a observar lo siguiente. Si tenemos el flujo hacia arriba, tenemos un aumento de la presión, por ejemplo, con una valsalva, se produce un flujo hacia abajo, se cierra la válvula con un reflujo trasciente, se cierra la válvula y después sigue hacia arriba. Si la válvula queda abierta porque está insuficiente, el flujo se sigue hacia abajo en contra el sentido normal. Y si mientras más rota, más alterada esté la válvula, peor va a ser el reflujo. Y eso es lo que se ve. No se ve, ya, no importa. Después tenemos, de la otra forma, es forzar el flujo retrógrado, o sea, no empujar de arriba, sino que atraer hacia abajo el flujo. Y eso se hace a través de estudio con el sístole y diástole muscular. Si ustedes tienen un sístole muscular, el flujo se va a empujar hacia arriba, digamos, hacia el corazón, y después, cuando hagan el diástole muscular, el flujo va a actuar como una esponja de nuevo, como decíamos, y se va a retroceder el flujo, se va a cerrar la válvula. Y eso es lo normal. Así que esto pasa cuando la válvula está abierta y esto pasa cuando la válvula está más alterada todavía. ¿Cuáles son los criterios de reflujo? Mayor de 0,5 segundos, mayor de 1 segundo sería severo y las válvulas patológicas, y las venas patológicas serían más de 3 milímetros. Pero no escriban nada todavía, cuidado. ¿Por qué? Porque todo depende del paciente, los diámetros dependen del paciente. Obviamente una persona delgadita con venas finas, si tiene 3 milímetros puede estar patológica, pero si una persona deportista, un cabro deportista, tienen venas mucho más grandes que no son patológicas, ¿ya? Entonces, podemos ver venas normales más grandes y, ojo, pueden haber venas menores, más chiquititas que tienen reflujo. Ahora, ¿por qué lo del tiempo también hay que tener cuidado? Esto, por ejemplo, es una callado de la safena interna, va llegando, aquí tenemos absolutamente destruida la válvula y el reflujo es un reflujo muy importante pero corto. Y este otro, hay una válvula que está fallando más o menos, pero el flujo retrógrado es más mantenido. ¿Cuál estará peor? Si lo vemos por tiempo, uno diría que pero no. Y las perforantes ya hablamos algo, una perforante mayor de 3 o de 3,5 milímetros es patológica, siempre es patológica si está subyacente a una úlcera, esté activa o no, y el reflujo es en el diástole muscular. Acá tenemos ejemplos que van a unas epifaciales y acá tenemos una que va a un lago, a varias estructuras venosas. Esto es importante, el pie. El pie, normalmente las venas, las perforantes tienen las válvulas que van hacia adentro, o sea, es decir, que no se deben abrir cuando sale hacia afuera de la sangre. En el pie, por ser un sistema cerrado, o sea, no es cerrado, pero compacto, en que aumenta mucho la presión, hay unas perforantes que tienen un flujo reverso, o incluso hay perforantes que tienen una válvula que están al revés o que no tienen válvula. Entonces pasa que cuando tú tienes el diástole muscular, el flujo, esta es la tibial posterior, se va por arriba, por la tibial posterior, y el flujo va de superficial a profunda. Esta es la vena del arco. Pero en el sístole, para que no haya un aumento excesivo de la presión dentro del pie, muchas veces el flujo va hacia afuera durante el sístole hacia el sistema superficial. Por lo tanto, ojo con hablar de que estas son insuficientes, porque no son insuficientes, ¿no? ¿Cómo reproducimos el sístole y el diástole? A través de contracción de los músculos o la maniobra para nada, que uno lo empuja o comprime, se carga sobre las piernas o se comprimir hacia abajo los músculos. O uno puede hacer que suban los dedos del pie, con lo cual también comprime los músculos. En cuanto a la fisiopatología, es un círculo vicioso en que tenemos una incompetencia valvular, ya sea congénita o por destrucción de válvulas por la TB, por ejemplo, que lleva un flujo reverso, lo cual lleva a una hipertensión venosa que también puede ser secundaria por otra cosa, por una insuficiencia cardíaca derecha, por ejemplo. Se producen dilataciones venosas, con lo cual se sobrecarga el sistema superficial y empieza este sistema del shunt veno-venoso o fístulas arteriovenosas, lo cual lleva además a incompetencia valvular. Entonces, ¿qué es lo que llamamos un shunt veno-venoso? Tenemos una vena profunda en que hay un punto de fuga, que puede ser un callado o puede ser una perforante, en que tenemos un trayecto retrógrado, que son las varices que están insuficientes, y un punto de entrada. O sea, siempre tiene que haber un punto de entrada, porque si no, como la sangre tendría que, tiene que entrar por alguna parte hacia el sistema profundo para que suba. Los patrones de reflujo, uno también conoce esto como para tener una idea de cómo va a lo que hay que buscar. Podemos tener callados insuficientes, que es lo más fácil en realidad. Estos patrones son, uno ve que callados insuficientes, ve la insuficiencia, ya sea hasta abajo de la safena interna o a través de la safena accesoria. Pero ya empezamos con problemas cuando los callados son suficientes, en que hay que buscar si vienen de arriba las insuficiencias de las epigástricas, por ejemplo, o de las venas vulvoperineales o de la safena mayor. El reflujo safeno externo también puede ser con callado insuficiente, que es lo más fácil, pero también puede ser que el callado esté bien y vengan de otro lugar. Y este es el reflujo no safeno, que especialmente se ve cuando están operados y que en realidad cuesta encontrarlo. Hay que buscar perforantes que estén insuficientes en las zonas que ya hemos visto. Un punto importante son las varices vulvoperineales, que determinan presencia de varices que van hacia sistemas epifacial, hacia abajo, o hacia el sistema safeno mayor, por ejemplo, pasando más abajo de una válvula que está suficiente. Los reflujos pelvianos, por varices pelvianas, son los que producen estas varices vulvoperineales, en que hay varios puntos de escape por donde salen hacia la extremidad inferior. Y lo que uno más ve son los del conducto inguinal, que son a través del ligamento venoso que se permeabilizó el conducto inguinal y se ve acá las varices, incluso no en pacientes que no están embarazadas, gente normal. Y los otros son el punto perineal, por ejemplo, que también descarga hacia las venas vulvares, que por eso que se producen estas varices acá. También hay otras que son glúteas, que van por detrás. Todo eso es importante saberlo como para buscarlo. Entonces, los requisitos del estudio es descartar una trombosis venosa siempre, de pie para asegurar la adecuada presión sobre las válvulas, buscar insuficiencia del sistema profundo y superficial, determinar los puntos de fuga, que son estos que alimentan los puntos, los paquetes varicosos, identificar las perforantes insuficientes. Se hace en una tarima para que no quede tan bajo. Nosotros antes lo hacíamos con una cinta para medir la altura. Uno se pone de acuerdo con los vasculares que trabaja y si es que quieren eso o basta que les diga dónde están de forma tercio superior, medio inferior, las perforantes, y describir las perforantes. Entonces mandamos un esquemita como esto es lo último ya. Tenemos, por ejemplo, este paciente, así dice el esquema. Entonces tenemos un callado de safena interna insuficiente, dilatado, siempre poner el diámetro especialmente de la safena. Acá tenemos que sigue dilatado hasta el final. Esta es safena interna o mayor. Este es el arco posterior, que hay un arco posterior insuficiente, que está dilatado, varicoso, y que se comunica con el sistema safeno externo, haciéndolo insuficiente hacia abajo. Y aquí está suficiente. Eso es información importante para saber dónde ir a a tratar. Este otro caso, por ejemplo, que está operado, y esto es terrible, porque ¿dónde están las varices? Entonces probablemente acá no tenemos unas varices, perdón, acá está interrumpida la safena, pero acá hay una safena accesoria que no fue interrumpida. Entonces se reprodujeron varices a través de ese vaso y de una perforante insuficiente que está en la cara lateral del muslo, que siempre búsquenla, es bien importante ahí, y que da estas varices de acá, ¿no? Y que van descargando acá a sistemas perforantes como este, que es una perforante de entrada. Acá hay otra perforante insuficiente. Antes, cuando este esquema es muy antiguo, lo hacíamos midiendo desde el maléolo hasta la perforante. Después estuvimos midiéndolo desde el suelo hasta donde están las perforantes, y ahora solamente decimos que está en el tercio superior, medio e inferior. Porque eso depende, porque muchos equipos trabajan con ecógrafos en pabellón, entonces es más fácil ubicarlo. Recomendaciones, lo último, esto es lo último. No asustarse al ver un paciente lleno de varices. Usar mucho gel, no comprimir, realizar estudios sistemáticos y ordenados, seguir los vasos safenos sin considerar las tributarias, cosa que ver bien, primero hacer un diagnóstico del safeno y después del resto, ver las tributarias, paquetes varicosos y mucha paciencia. Ahí sí, eso.